Chapter 39, Immobility. Here's your scientific knowledge base. We know movement requires a coordinated effort between both the musculoskeletal and the nervous system. Our body mechanics are important, alignment and balance, which includes our posture. Remember, gravity plays into it, as well as friction and shear, which we're going to talk about in a little bit. So the skeletal system provides attachment for all our muscles and ligaments, protects our vital organs, aids in calcium regulation, which helps our muscles work, provides leverage for mobility. We have bones that are long, short, flat, or irregular. Our joints, which move in different directions. Ligaments, tendons, and cartilage all support and are part of the musculoskeletal system. So muscle movement and posture. Skeletal muscles are working elements of movement. The nervous system regulates movement and posture. Pathological influences on mobility. Postural abnormalities. These can include congenital abnormalities or acquired abnormalities through injury or disease. Damage to the central nervous system and musculoskeletal trauma. What factors influence mobility? Are we able to move about freely? Immobility means we are unable to move around freely. Bed rest can impact mobility. Muscular deconditioning occurs very quickly, especially the older the client is. We have disuse, atrophy, physiologic, psychological, and social as well that all impact our ability to move. Metabolic changes can also impact our ability to move because the endocrine system secretes hormones which maintain and regulate vital functions. It impacts our ability to respond to stress and injury. So endocrine metabolism, calcium reabsorption, and the function of our GI system all are important. Our endocrine system helps maintain homeostasis. Immobility disrupts normal metabolic functioning. So a decreased metabolic rate, altered metabolism, causes GI disturbances. So what are the systemic effects? Well, here's a chart from your textbook that shows you the effects all of our different systems have on our mobility. Metabolic, cardiovascular, muscle effects, urinary elimination, respiratory, musculoskeletal changes, skeletal effects, and integumentary. All of this impacts a client's ability to move. Respiratory changes. Immobile clients are at high risk for pulmonary complications like pneumonia. They can get atelectasis, which can lead to hypostatic pneumonia. Do you notice a respiratory change in your immobilized post-operative patient? The change you note is most consistent with cardiovascular changes, orthostatic hypotension, increased cardiac workload, and thrombus formation. Musculoskeletal changes, muscle effects, lean body mass loss, muscle weakness and atrophy. Skeletal effects, you can get a disuse, osteoporosis, and a joint contracture. Urinary elimination changes. We can get urinary stasis, renal calculi, and they're more prone to infection of the urinary tract. Integumentary changes, they are more prone to pressure ulcers from not moving around. You get inflammation and then ischemia. Older adults are at greater risk for this. Psychosocial effects, emotional and behavioral responses. You may see hostility, giddiness, fear, and anxiety in the client. Altered sleep patterns. You may see depression, sadness, and dejection because of the change in what's happening with their disease process or injury. So each of your PowerPoints has a case study embedded. We have Ms. Eileen Thomas, who is 82. She's admitted for a fractured right hip. She is on complete bed rest and buck traction. Sergio is the nursing student assigned to Mrs. Thomas. You notice a respiratory change in your immobilized postoperative patient. The change you note is most consistent with So developmental changes are important because this is associated with immobility in the very young and older adults. Now, this course is only for adults and aging adults, but we do mention infants, toddlers, and preschoolers, which we'll learn about in pediatrics, and adolescents. Adults' physiological systems are at risk, changes in family and social structures, and then older adults, they have decreased physical activity, hormonal changes, and bone reabsorption, which is a normal part of aging. So Ms. Thomas' mitral valve was replaced 2 months ago, and since the time of surgery, she has been on anticoagulants. She has had type 2 diabetes mellitus for the past 10 years and is a smoker. She weighs 195 pounds and is 5 feet 7 inches tall. She lives by herself and she attends Mass daily. Her pain is a 6 on the scale of 1 to 10. So we're going to apply the nursing process. What's your assessment? You want to see through the patient's eyes. What's her range of motion? Are the planes of her body in alignment, sagittal, transverse, and frontal? So what's her range of motion? Contractures can develop and joints not move, so we want to periodically put her joints through their full range of motion. Her neck, shoulder, elbow, forearm, wrist, fingers, thumb, knee, hip, ankle, foot, and toes are all important. Any joints that are movable, you're going to gently help her with passive range of motion. Now, active range of motion means that's what the patient does. So mobility, gait is a particular manner or style of walking. So the next time you're out and about, watch how people walk. Exercise, activity tolerance, physiologic, emotional, and developmental. Are they able to tolerate normal activities? Body alignment is used for determining normal changes, identifying deviation, making the patient aware of their posture, identifying learning needs of clients, identifying trauma, muscle damage, or nerve dysfunction, and obtaining information on incorrect alignment. Here's proper body alignment standing, proper body alignment sitting, proper body alignment laying, and this is a side-lying picture. So what are the physiologic hazards of immobility? Well, it affects all of the body systems. So here's some nursing diagnosis that you might use for a patient who has impaired physical mobility or is at risk for disuse syndrome. So now we need to plan our care. We need to set reasonable goals and outcomes. What are the priorities? And then use teamwork and collaboration to help us attain those goals and outcomes. So health promotion. We want to prevent work-related musculoskeletal injuries. We want to encourage exercise and monitor bone health in patients that have a diagnosis of osteoporosis. So we want to provide a high-protein, high-calorie diet with vitamin B and C supplements. We want to cough and deep breathe every 1 to 2 hours and provide chest physiotherapy. So consider Eileen Thomas' medical history of type 2 diabetes mellitus, heart valve replacement surgery 2 months ago, and being an active smoker. So cardiovascular, we want to reduce orthostatic hypotension, reduce the cardiac workload, prevent thrombus formation. So we're going to use sequential compression devices, thromboembolic disease hose, TED hose, and leg exercises to help her. So we want to prevent muscle atrophy and joint contractures from being in bed rest because she's in traction. So we want to reposition her every 1 to 2 hours and provide skin care, paying special attention to bony prominences and points that she's been recently laying on. We want to provide adequate hydration. So we want a diet rich in fluids, fruits, vegetables, and fiber. So we need to think about psychosocial changes and developmental changes. So here are your positioning techniques. We do a supported Fowler's. We can do supine, prone, side lying, and Sims. And it's important that we know what all of these positions are. Your book has pictures, and you're going to learn about it in the lab this week. So safety is your first priority when moving patients. You want your patient safe, and you want to be safe. We want the patient to help as much as possible. Determine if the patient understands what we expect of them. Are they comfortable? Because if they're in pain, they're not going to want to move or help you. Determine if you need assistance in moving the patient. Please ask for help. It will help you prevent injury. So we want restorative and continuing care for IADLs, range of motion exercise, and walking. And IADLs are independent activities of daily living. So through the patient's eyes, is this plan of care realistic for this client? Do they understand it? We need to evaluate the effectiveness of specific interventions, evaluate patient and the family's understanding of all teaching. You want to engage your family members or the friends of the client who are there. So, safety guidelines for your nursing skills. Determine the amount and type of assistance required for safe positioning. During positioning, raise the side rail on the side of the bed opposite where you are standing. Arrange equipment so that it does not interfere with the positioning process, and evaluate the patient for correct body alignment and pressure risks after repositioning.